Run 2 fingers along the bridge of your nose. Feel the hard ridge under the skin. Now slide them just a fraction higher, right between your eyes, and press gently inward. That resistance, that thin wall of bone you're pressing against, most people will live their entire lives without knowing its name. It's called the vomer, thinner than a credit card, barely 2 inches tall in most adults, and after the age of 40, it is quietly, measurably shrinking. I came across this almost by accident. I've been looking at CT scans of patients in their 50s and 60s, people who came in with breathing complaints, sinus pressure, a sense that their face had somehow flattened over the years. And when I started comparing their mid-face architecture to scans from their late 30s, the same structural shift kept appearing. The vomer had lost vertical height. In some cases, a full millimeter or more. That sounds like nothing, a millimeter. But in a structure this thin, in a location this central, a millimeter is catastrophic. Here's why that threw me. We talk about facial aging constantly. Collagen loss, skin laxity, fat pad descent. Entire industries exist around the surface of the face. But the scaffolding underneath, the actual bony architecture that determines where everything sits, that conversation barely exists outside of maxillofacial surgery departments. The vomer sits behind your nose, runs vertically from the base of your skull down to your hard palate. And it does something that no other facial bone does in quite the same way. It holds the septum in position. The septum holds the bridge of the nose. The bridge of the nose holds the projection of the midface. And the projection of the midface determines the position of your cheekbones, the width of your airway, and the resting posture of your jaw. One bone holding a chain. Think of the midface as a stone arch, the kind you'd see in a Roman aqueduct. Every stone matters, but one stone matters more than all the others combined. The keystone, at the apex. Remove it, and the arch doesn't just weaken, it collapses symmetrically, both sides falling inward toward the center. The vomer is that keystone. And here's the nested part that makes this analogy tighter than it first appears. Inside that keystone, there's a layer of periosteum, the living membrane that wraps the bone and feeds it minerals, blood supply, regenerative signals. The periosteum is like the mortar between the stones in that keystone. When the mortar degrades, the keystone doesn't shatter all at once. It develops microfractures. It loosens, and the arch above it starts to settle, millimeter by millimeter, year by year. Robert Corricini, an anthropologist at Southern Illinois University, spent decades documenting how facial structure varies across populations. Not genetically, but mechanically. Populations that chew tougher, less processed foods show markedly different mid-face projection and dental arch width compared to populations eating soft, industrialized diets. The mechanical load on the maxilla, the palate, and the bones connected to them, including the vomer, appears to directly influence how those bones maintain density over a lifetime. His work is weird to encounter for the first time because the implication is immediate. The way modern humans eat, breathe, and use their faces may be accelerating the very bone loss that reshapes them after 40. So what happens when the vomer starts to thin? I want to trace this cascade precisely because each stage makes the next one worse. And once I lay it out, everything about mid-face aging starts to click into place differently. Stage 1, the vomer loses vertical height. The septum, which was held taut by the vomer's superior edge, begins to descend. Not dramatically, a fraction of a millimeter per year, but the septum's position determines the internal architecture of the nasal cavity. As it drops, the nasal passages narrow slightly. Airflow resistance increases. Breathing through the nose becomes marginally harder, especially at night, especially during sleep. Stage 2, the maxilla. The bone that forms your upper jaw in the floor of your eye sockets begins to retract. The maxilla depends on the vomer and the septum for anterior projection. As those structures recede, the maxilla follows. Dr. Robert Shaw's craniofacial aging research documented this retraction pattern across hundreds of patients. The midface moves backward and downward simultaneously, pulling the cheekbones flatter and the under eye area deeper. Stage 3, the mandible repositions. With the maxilla retracted, the lower jaw compensates. It shifts slightly backward and downward to maintain occlusion, the way your teeth meet. The jawline softens, the chin recedes. The submental area, right under the chin, develops a fullness that has nothing to do with fat and everything to do with skeletal repositioning. Stage 4, and this is where it starts to compound. The airway narrows further. The mandible's posterior shift reduces the space behind the tongue. Airway resistance goes up again, on top of the nasal restriction from stage 1. Breathing quality degrades, sleep quality follows. And here's the compounding element. Poor sleep accelerates bone loss systemically, because the deepest phase of sleep, N3, slow wave sleep, is when growth hormone peaks. And growth hormone is one of the primary signals for osteoblast activity, the bone building cells. Less deep sleep, less bone building, more resorption, more facial recession, worse sleep. A loop. I want to put this in financial terms because the compound dynamics are almost identical. Imagine your facial bone density as a savings account. Every year, deposits come in. Mechanical loading from chewing, tongue pressure, nasal breathing, and withdrawals go out. Osteoclast activity, hormonal shifts, systemic inflammation. Before 40, the deposits roughly match the withdrawals. The account balance holds. After 40, the withdrawals start exceeding the deposits. Not by a lot, maybe 2 or 3% per year. But here's the nested layer. The interest you earn on that account, the bone's ability to respond to mechanical loading and rebuild, depends on the current balance. As the balance drops, the interest rate drops with it. The less bone you have, the less efficiently your body rebuilds bone. The less it rebuilds, the faster the balance falls. Compound interest, running in reverse. And unlike a financial account, there is no external bailout, no lump sum deposit to reset the balance. The only intervention is changing the deposit and withdrawal rates before the balance crosses the threshold that makes recovery exponentially harder. Now, I need to validate something that many of the people watching this have already sensed. If you spent money on serums, retinols, fillers, or even surgical procedures for your face, and the results faded faster than you expected, or the improvement looked right in photos but felt somehow incomplete in the mirror, that frustration is legitimate. It's not that those interventions don't work. They do on their own terms, but they operate on the surface layer of a structure whose foundation is shifting. A filler can restore volume to a cheekbone that is flattened. It cannot restore the maxillary projection that made the cheekbone prominent in the first place. A retinol can improve skin texture over a retracting bone. It cannot stop the retraction. Different medical traditions have approached this from opposite ends for centuries. Western dermatology and aesthetics developed extraordinary tools for the surface, the skin, the fat pads, the muscle tone. Meanwhile, traditions rooted in manual therapy, cranial osteopathy, and structural bodywork focused on the architecture underneath. Neither tradition has been wrong. They've been incomplete in complementary ways. The practitioners I've seen get the most consistent results are the ones who bridge both, addressing the surface and the scaffolding simultaneously. That pattern shows up across every clinic, every population, every age cohort I've observed. So the question becomes practical. How do you support a bone you can't see, can't touch directly, and didn't know existed until 10 minutes ago? I want to offer a framework rather than a prescription because individual variation here is enormous. 3 questions. Each one points to a different category of intervention, and together they cover the territory. The first question, is the bone getting the mechanical load it needs? Here's what that looks like in practice. A woman in her early 50s. I'll describe her morning because it illustrates the framework better than a list ever could. She wakes up and before she reaches for her phone, her tongue is already pressed firmly against the roof of her mouth. The full blade of the tongue, not just the tip. Pressed upward with enough force that she can feel the pressure in her cheekbones. She's been doing this consciously for about 3 months. It's nearly automatic now. That sustained upward pressure loads the palate, which loads the maxilla, which loads the vomer. During breakfast, she chews, deliberately, longer than she used to. Tougher foods, raw carrots, nuts, sourdough crust. Each chewing cycle is a micro-loading event for the bones of the midface. The periosteum registers the mechanical signal and responds by upregulating osteoblast activity. More chewing, more signal, more bone maintenance. She also does something unusual. 3 times during the morning, she places her thumb against the inside of her upper gum line, just beside the hard palate, and presses outward and upward for about 30 seconds per side. This is intraoral pressure, a direct mechanical stimulus to the maxillary bone through the soft tissue. Mike Mew, the orthodontist who formalized orthotropic principles, has argued for decades that the maxilla responds to sustained mechanical input throughout life, not just during childhood development. The clinical patterns I've observed support this. Adults who maintain consistent tongue posture and mechanical loading show measurably slower midface recession than those who don't. The second question, is the metabolic environment supporting mineralization? This same woman takes vitamin K2, the MK7 form specifically, paired with vitamin D3. K2 directs calcium into bones and teeth rather than allowing it to deposit in soft tissues and arterial walls. Without K2, D3 mobilizes calcium but doesn't guide it. She also monitors her magnesium intake because magnesium is a cofactor for over 300 enzymatic reactions related to bone metabolism. Her evening routine includes nasal breathing during sleep. She uses a small strip of medical tape over her lips, which felt strange for the first week and now feels indispensable. Nasal breathing maintains the mechanical relationship between the nasal cavity, the septum, and the vomer. Mouth breathing bypasses this system entirely, and chronic mouth breathing is associated with accelerated midface recession in the clinical literature. The third question, is the soft tissue allowing the bone to maintain position? She stretches her neck and anterior throat twice daily, long, slow extensions that open the fascial planes running from the chin to the sternum. Weston Price, the dentist who documented facial structure across dozens of traditional cultures in the 1930s, observed that populations with broad, well-developed midfaces universally maintained open anterior neck posture and strong tongue-to-palate engagement. The soft tissue environment around the midface either supports the bone's position or pulls it downward. Forward head posture, chronically tight SCM muscles, a tongue that rests on the floor of the mouth instead of the palate. These soft tissue patterns exert continuous downward and posterior force on a skeletal system that is already losing the density to resist. Let me tell you what the pattern looks like among the people I've worked with who adopted this framework consistently over 12 to 18 months. The before picture, broadly, looks like this. Flattened midface, narrower nasal passages, jaw slightly posterior, under eye hollowing, mild to moderate snoring or mouth breathing at night. The after picture, not a transformation. I want to be careful about the scope of that claim. This is partial reversal and significant stabilization, not reconstruction. What I consistently see is restored nasal airflow, improved cheekbone projection visible in profile photographs, reduced jaw tension, and dramatically better sleep quality. The sleep improvement appears first, often within the first 6 to 8 weeks. The structural changes in the face take longer, 4 to 6 months before they're visible, 8 to 12 before they're unmistakable. Among the subset who combine the mechanical loading with the metabolic support and the soft tissue work simultaneously, the results are more pronounced than in those who adopt only 1 or 2 of the 3 framework pillars. That pattern holds across every age group I've tracked, from mid-40s through early 70s. There is a part of this I haven't explored yet, and it's the part that keeps pulling at me. The vomer doesn't exist in isolation. It articulates with the sphenoid bone above, and the sphenoid articulates with the temporal bones In the temporal bones house the mechanisms of balance and hearing. There is a downstream relationship between vomer recession and changes in vestibular function, equilibrium, and even auditory processing that I am only beginning to trace through the clinical patterns. That investigation is far from complete, but the preliminary observations are striking enough that I cannot set them aside. The chain from a thinning bone behind the nose to a shift in how someone perceives spatial orientation is longer than I expected and more coherent than I was prepared for. The people I see pursuing this framework share a specific quality. They came in with a frustration they couldn't articulate, a sense that their face had changed in a way that skincare couldn't address, that fillers couldn't reverse, that no mere angle could fix. When they learned about the vomer, about the keystone and the cascade and the compound loss, something settled. The frustration had a name, and a name is the first condition for a strategy. Among those who stayed with the framework, the consistency of improvement has been the most compelling evidence I can offer, more compelling than any single scan or measurement. The pattern is clear, it is reproducible, and it begins with the same thin ridge of bone sitting quietly behind the bridge of the nose.